Good afternoon and welcome to one more episode of Your Intervention on Air. My name is Julia Grabsa, an imager passionate about echocardiography and also social media editor for Euro Intervention. And it is a great pleasure to introduce Professor Guy Whitberg, interventional cardiologist from Rabin Medical Center in Petah Tikva in East Israel, and first author of the manuscript Outcomes and Predictors of Left Ventricular Recovery in Patients with Severe Left Ventricular Dysfunction undergoing transcatheter aortic valve implantation, which was published on Eurointervention April 15th. For those of you that you are interested to find out more, go back and read the paper after our podcast, of course. And for the audience, feel free to submit your questions on all social media platforms with the hashtag EIJ on air. So, Guy, lots of congratulations. This is an amazing manuscript. I was fascinated. Could you please tell us more about your study?
Yeah, thanks, Julia. Thanks for having me. So what we did in this study is collect data from multi-center registry of 17 TAVI centers in Europe and Israel. And again, what we wanted to do is focus on patients with baseline severe LV dysfunction, that is an EF of under 30% undergoing TAVI, to see what happens to those patients, specifically what happens to their EF. What we wanted to see is use the follow-up echocardiography data and see how many of these patients achieve LV recovery, which we defined as an increase of at least 10% in EF within 90 days following TAVI. Our sample size was just over 10,000 patients, and of these, the fraction of those with severe LV dysfunction was just under 8%. We had almost just over 900 patients with severe LV dysfunction. And what we saw is that following TAVI, significant fraction, actually most of these patients did show LV recovery. 60% of patients showed LV recovery. That is an improvement of at least 10% in EF. And even more interesting, almost a third of these patients, 26%, showed complete normalization of LV function. That is achieving an EF of over 50% within 90 days post-TAVI. Again, all in patients who had a baseline EF of less than 30%. So that was the first thing we did in this manuscript. The other thing we wanted to see, obviously, is what's the prognostic effect of LV recovery. And as you would expect, those patients who did have LV recovery had much better prognosis than those without. Our primary endpoint was 3 years mortality. And what we saw is that actually patients with LV recovery had the same 3-year mortality or similar 3-year mortality as patients with normal LV function at baseline. Perhaps the most interesting is that the patients who showed LV normalization actually had the best prognosis of all groups. They actually had 20% reduction in 3 years mortality compared to those with normal LV function at baseline. So again, that was something that we expected to see, that LV recovery and LV normalization is associated with better prognosis. The last thing we wanted to do is try to identify factors that are associated with higher likelihood of LV recovery. And we identified 3 such factors. First was not having a history of previous MI. Second was mean AV gradient at baseline of over 40 millimeters of mercury. And third was an eGFR of over 60 millimeters per minute. So again, that allows us to better assess what's the likelihood of LV recovery. So those are the main findings of the manuscript.
Very interesting findings, and congratulations again for all this hard work. And let me start from the most important part, which are the clinical implications. Do you feel that our clinical practice will or should change after this study?
So again, I don't think the issue is change in clinical practice. The reason we wanted to do this analysis, the reason we wanted to do this study, was because this is a clinical dilemma that we face in everyday practice. As I've said, 1 in 11, 12 patients that we had who has a TAVI has baseline severe LV dysfunction. So in high volume centers, we treat these patients on a weekly basis. And the difference between such a patient and a patient with normal LV function lies more in our ability to predict the benefit from TAVI. Because when we have a TAVI patient with severe AS and normal LV function, we're quite certain in telling them that we know that if we're going to have a successful TAVI, your symptoms will improve, your quality of life will improve, and the risk associated with TAVI is worth taking for those expected benefits. When you have a patient whose baseline LV function is severely reduced, we're not that sure. We know that if the LV recovers following TAVI, then most likely then the symptoms will improve and the quality of life will improve, but we can't say the same if the LV does not recover. So I think that was the main issue that is important for these patients. And I think that the main value of the results that we published is that it allows us to have a better informed discussions within our heart teams to assess the likelihood of LV recovery and decide which patients we think are more likely to benefit from TAVI. And it allows us to have better informed discussion with our patients after we decide what our strategy will be, and reflect to them what's their expected risk-benefit ratio if they decide to have a TAVI. And again, I don't think that the correct interpretation of our results should be that patients with features that are not associated with a high likelihood of LV recovery should be refused from TAVI. I don't think that's the correct interpretation. Such patients should still be assessed for TAVI, and a lot of them can benefit from TAVI, but the lower likelihood and the lower benefit expected to them should be reflected to them, and then they should make their decision whether or not they want to take the associated risks associated with TAVI.
As you say correctly, it's everything about expectations. And we see that you have two different types of patients that they will actually show best results following TAVI. These patients that they are able to generate a mean gradient more than 40 millimeters per mercury, and of course those that they don't have a scarred ventricle, that they didn't have ischemia, of course, as we call it. Do you feel that these patients with a mean gradient more than 40, they actually had better contractile reserve? That's why they showed best results following TAVI? And how important is, a functional test?
Mm-hmm. So that's an excellent question and a very important point. And I think that, again, overall, we know that in the overall TAVI populations, patients with high gradients do better than patients with low gradients. And again, it's very tempting to say, and again, our data show that patients with a mean AV gradient of over 40 do have better prognosis, and again, have higher likelihood of LV recovery. And it is very tempting to use that as a surrogate for contractile reserve, even though that's not exactly the same. And I think what's interesting is that if we look at the guidelines today in patients with LV dysfunction but high gradients, you're not supposed to assess contractile reserve because those patients aren't supposed to have a DSC as part of their TAVI assessment. The role for DSC in current guideline is that we use that to confirm the diagnosis of severe AS in patients with low flow, low gradient severe AS. And our data shows that perhaps beyond the diagnostic purposes, that can also have prognostic. We can use that for prognostic stratification as well. And again, in our study, we didn't directly examine contractile reserve because, as is common in clinical practice, most patients don't have a DSC as part of their TAVI assessment, even if they have severe LV dysfunction. What I can say is that again, in our case, we had about a third of the patients had available DSC results, and those weren't included in this study, but we've just submitted for publication a follow-up study that we did that focused on that group of patients, about 300 patients with severe LV dysfunction that had a DSC prior to TAVI, and the results showed that, again, that contractile reserve was a major determinant of LV recovery, and those patients who had contractile reserve had much better prognosis following TAVI, again, because of their LV recovery. So perhaps we'll talk about that separately when that manuscript is published. But I do think that the overall message should be that contractile reserve should be assessed, and I think that in general, DSC should have a much more prominent role in the assessment of patients with LV dysfunction who are being assessed for TAVI. First of all, according to current guidelines for the confirmation of the diagnosis, and I think we will have data suggesting that it's also relevant in terms of risk stratification and to assess the prognostic benefit, because patients with contractile reserve will have better prognosis following TAVI.
That's fantastic. Thank you. And coming to revascularization, Guy, if it was to choose, we have two options: revascularization and TAVI versus revascularization. Actually, revascularization and TAVI, TAVI and guideline-directed medical therapy. Which one would you choose?
So again, that's a very good point, and I think that's one of the most hotly contested issues in TAVI today, the whole issue of revascularization, because again, there's a very high prevalence of coronary disease in the TAVI population. But until today, we have very limited data supporting any benefit from percutaneous revascularization in the TAVI population. And again, if we stop for a minute and actually think about the overall heart failure LV dysfunction population, we know that percutaneous coronary intervention in severe LV dysfunction is not effective. It's not beneficial. We know that from Revived. If we move and think about the overall TAVI population, so again, we know that revascular PCI in the overall TAVI population is not associated with any benefit. We know that from activation, which again was a limited study that does not reflect current practice. But again, there's no strong data to suggest that revascularization improves any outcomes in patients being assessed for TAVI. The point that you made, and I think is crucial, is the whole issue of medical therapy. And we know that guideline-directed medical therapy is effective in patients with LV dysfunction. And I think a key issue is that when we discuss patients with severe S and severe LV dysfunction, the basic thing we need to see is that they are already on their optimal heart failure medication. And if they're not, then we need to wait, and we need to make sure that we're getting them on the best medication that is possible. And after that, we need to assess them clinically, see if they're still symptomatic, and then decide if we want to proceed to TAVI. And again, what our data shows is that TAVI is an effective treatment for LV dysfunction in suitable patients. And I think that's not very surprising if you remember that, again, the way our heart failure treatment works is targeting two mechanisms. One is the neurohormonal axis inhibition, and the other one is being afterload reduction. And again, there's probably no better intervention to reduce afterload apart from TAVI or surgical AVR. So it's not surprising that it is effective, and again, that the likelihood of LV recovery is quite high. Perhaps the interesting thing, or the most important thing, is to be able to predict which patients with severe S and LV dysfunction will not respond well to TAVI and will not recover. Their LV function will not recover, and in those patients, we need to consider other options as well.
Thank you so much. I was thinking the time that you were talking and explaining this concept, how beautifully you merged actually heart failure, imaging, and interventional cardiology, and you brought to the surface the value of the heart team once again, that, we keep saying about the importance of guideline directed medical therapy, and of course then the patient to have an intervention. So I don't know if you have any take home messages. We reached the end of the podcast. Like a couple of words of why someone needs to read this manuscript that I find amazing.
So I think that perhaps the take-home message from this study should be that if you look at patients, if you're treating a patient with severe S and severe LV dysfunction, all these patients can be put on a spectrum. And on one end of the spectrum are patients with established cardiomyopathy, most likely ischemic cardiomyopathy, that over the years developed severe S. On the other end of the spectrum are patients with, let's call it, pure valvular cardiomyopathy. And most of the patients are somewhere in the middle. But the closer you are to the valvular end of the spectrum, the more likely you are to recover to see LV recovery after TAVI, and the benefit from TAVI will be much higher. The closer you are to the ischemic part of the spectrum, the less likelihood you'll be to show LV recovery, and your outcomes will be worse. Again, that's not to say that those patients on that part of the spectrum should be automatically refused from TAVI, but I think that this is a concept that we need to be more and more aware of, that we need to assess where on that spectrum a patient lies, and basically the next step is to have better prediction tools to be able to assess it more accurately. What's the likelihood of of LV recovery in those patients?
Thank you so much, Guy. Congratulations again on this amazing work. And for the audience, stay tuned for the next episode of Euro Intervention on Air, and also all the initiatives from Euro Intervention. Thank you so much for